really glad to be here to share what we have as our Medical Education Journal Club. And I want to start off by just saying who we are and then finding out who you are. So we have Chad Brown and Will Peterson over here from University of Michigan. I am David Duong. I'm from Highland Hospital. We have Esther Chen from UCSF and David Gordon from Duke. I want to find out here, if you could raise your hand, first of all, how many of you are medical educators here? Phenomenal. Clerkship directors. Okay. APDs and PDs. Fantastic. And also, how many of you were at our session at Cord? Oh, okay. Well, we have revamped it. There's going to be some of the stuff that we presented, but just a minority. And then we've expanded upon it just to give you some fresh stuff. Because really what we did is we scoured the literature from last year. And we wanted to see, hey, what is the national discussion? What are people talking about in medical education, not just in emergency medicine, but also nationally and across specialties. So that's what we want to get across. Okay, so how it's going to work today is that we're going to do some rapid fire studies, go over some of them quickly, and then we want to go take the second half and do a deeper dive, have a little bit more discussion on some of the things that we think are going to be really meaty. Okay, so I'm going to start first with the first three articles. And the first one, we do a lot of evaluations for us, for medical students, but not really for us, for residents, but not really for us. And so we want to find out, what can we do better as medical educators? And there was a group that came out of Germany that said, hey, we have a solution, and it doesn't require faculty development. It's cookies. So what they did was they did a randomized controlled trial, and they randomized medical students to either getting a cookie or not getting a cookie. So what they did was they did an acute coronary syndrome lecture, okay? And then half of the group got cookies, half the group did not get cookies. Just to kind of go in the weeds just a little bit. So they had two different teachers, not just one, but two different teachers who have taught this before. And then each of those teachers would give a lecture, and they would offer cookies, and at another time, they wouldn't. And so what did they find after they gave the survey? There was about 38 questions on there. Oh, another thing that was really interesting is they definitely got into the weeds. Very German paper. So they even had a reference, and they described the cookie, a drop cookie with a reference. Pretty amazing. Okay, so what did they find? They found that, yes, if you give cookies, not only do you get a better evaluation, but the whole session gets a better evaluation as compared to when you don't give a cookie. They did all these other statistics too to prove that, hey, this is an independent contributor to your evaluations. Okay, different ways you could kind of take this study. The next thing is, hey, what about the difficult patient? We've had this kind of patient. They've come in, our hairs stand on the back of our neck. It's pretty stressful. So some of us, we may elect to take a pill, but other times we send in the sacrificial lamb, the medical student. But really, how well equipped are our medical students? What do they know about handling the difficult patient, the interpersonally challenging patient? I don't know about you, but in my medical school, I'm not sure what is actually taught there. And so this is what this study sought out to find out. What do our medical students, how are they handling the difficult patient? What do they learn, and how can we help them in this situation? So they said, hey, who's going to be the best people to talk to? And so they decided to pick the student who, they have nothing to lose to tell you all what they feel about the difficult patient. These are medical students who have already matched in their fourth year, but not quite finished yet. We've had these students in our sub-Is who they've already matched. They're not going to emergency medicine, so we kind of get a feel for this. Also, they have been through 4 years of medical school, so they have a longitudinal view of what their curriculum is like. They did semi-structured interviews and a qualitative content analysis asking these students, hey, how do you handle the difficult patient? What strategies do you use? And then also, were you taught any of this stuff? And what could be better with us? How can we help you better with a difficult patient? So the first part of the study, when they did these interviews with students, the first thing that they found were there were 5 strategies that they employed. The first one, finding empathy and compassion, basically putting themselves in the patient's shoes. Maybe they're finding some empathy and compassion that way. The second one is trying various communication strategies. So for instance, active listening, reflective listening. Other things were anticipating difficult interactions. So hey, if they knew that this patient was probably going to be difficult, I mean, quite frankly, they might even spend less time, put time limits on them, on how much they would spend with a patient. Seeking support. So interestingly, they generally didn't seek support from us, from their clinical team. They would actually seek support from their peers, from people at home, from their friends and family actually, because they kind of mentioned that we're the ones evaluating them. They don't want to be seen as weak. You know, they could learn from us, but the fear is that it would affect them negatively. Though there was some comments that if there was some support from the team, it was really highly valued. Other things, the final thing that that came up was thinking of this as an opportunity. So they noticed that as a team, when there is a difficult patient, we as clinicians spend less time with them, veer away from them. So they're able to come in and give more time to the patient. So they thought, some of these students found an opportunity to become the primary care provider, not just standing back and observing and being, and not really interacting with the patient as much. So they found that. Things that they wish they had from us and from their medical school, these are some of the strategies, educational strategies they wish they had. So in terms of didactics, it wasn't just, okay, here's how to deliver the bad news. They've got that. But when you have a patient who's addicted to opiates, how does that work? How do you interact with them? What about when the patient doesn't want to leave the hospital? They wanted more directed didactics, and that included small groups too. And in these small groups, they were able to share with each other, but also find out, what do residents do? What do attendings do? How do we approach it? What goes in our mind? And in the small group setting. There's the clinical pre-briefs and debriefs. So medical students, they would love to have, hey, before you go in and see the patient, hearing us just say, how can we support you? Hey, here's some tips I use. And then when they leave, how did it go? You know, let's summarize. What can we do better next time? Things like that. Attending and resident monitoring. They want to watch us in action. How do we handle it? Though the funny thing is, the next thing they mentioned is, well, they've actually seen us not handle it well, so maybe we should be trained better with some faculty development. Okay, this next one, the final paper I have, I thought it was a really great paper that came out last year from the GW group. How do we spot an awesome EM resident? What are some of the qualities that go in to making an awesome EM resident? And so the methodology for this is that they did a Delphi methodology. So first they generated ideas from medical educators in emergency medicine, the CORD group, the Council of Residency Directors in Emergency Medicine. And they said, hey, give us some ideas. What do you look for? What indicates to you that you have a great resident? And then from that subset, they went through Delphi methodology with 6 emergency medicine program directors, and then went through 3 rounds of this process to come up with the final list of 20 things here. I also think, though, it's important, before I go into the 20, what didn't rise to the top? Because when I talked to Colleen Roche, PD at George W. and one of the investigators, she was thinking she would think there'd be more traits, more ingrained traits. You know, for instance, she thought being teachable would rise to the top, but it didn't, it fell. Other things that didn't happen to rise to the top were the milestones, the CCC. That didn't make it into indicating who's a great resident. Another thing I think is also very interesting is everything pre-residency. Like the stuff we look at ARS, board scores, AOA, clerkship grades, like all that fell off. No one looks at that to figure out whether they have a great EM resident or not. The one thing that did rise to the top was interviews, was residency interviews. Okay, so here is the list of 20. I'm not going to read them off to you, but I do want to make some comments about them. Just take a look at that and just think about what you use to evaluate your residents. Common sense, being curious, gritty. I mean, I don't have that in my CCC and milestones. I don't have that in my evaluation, so it made me think a little bit more. Other things to mention about this paper, the things that came out, were that they are, a lot of these things in that list of 20, you can take a look at them, they're teachable. They're factors that are teachable. Another thing is that these are things that I mentioned before that the CCC and the milestones don't really encompass. So the implications for this is that if you just are scratching your head, what can I do to really coach my resident to their full potential? But I can't seem to figure it out from my evaluations. I can't seem to figure it out from my CCC or milestones. Take a look at this list. This is stuff that we might be looking for. It might help you move that student to the next level or in remediation. Other things are implications for recruitment. Again, these are things that maybe we can ask our clerkship directors to put in the SLO. These are things that maybe we should be asking about in the interview. So important implications for this talk. Okay. The next, we have Esther Chen with the match.
Thank you, David. Unfortunately, we don't have much time to do questions, so at the very end, if we have time, we'll be able to go over some of these other topics. So the next hot topic is the residency match, and this particular paper is on the interview experiences of a cohort of interns from about 2 or 3, one interview season at one institution from a variety of different specialties about 2 or 3 years ago. And I just want to highlight, so this was a survey, and I want to highlight a few of the results. So over the course of the interview trail, applicants were asked at least once, about 72% of applicants were asked at least once about other interviews that they were going at in other institutions. The applicants were asked about marital status, so are they currently married, do they plan to be married? About 38% of applicants were asked this at least once. And then finally, applicants were asked about children. You know, do you plan to have children? Do you currently have children? So 17% were asked at least once. Primarily, those were women who were asked this question. They also surveyed the interns about the post-interview communication. And 70% of them said that they would be so relieved if programs would just actively discourage that post-interview communication. You know, that follow-up email that says, you know, I love your program, I'm going to rank you #1, etc. That just contributes to the overall stress of the interview season. So I think this study, even though there was a very small, only 31% of the interns actually completed the survey, so very small sample size. There's, of course, recall bias, but I think it's a good reminder for those of us who participate in the recruitment season. You know, there's some questions that we really just should not ask and should try to avoid, and perhaps we can all do a better job of discouraging that post-interview communication to try to alleviate some of the stress. On a related topic, this is the standardized video interview. So as many of you know, this last interview season was the second pilot year of the SVI. And so this particular study was from the first year of data. So that was a couple of years ago. And as you can see, here's just the range of scores over that first year. And this particular study involved 9 different institutions. They had faculty at each of these 9 institutions review all of the applications to their program. They used whatever factors that they ordinarily used, and they were blinded initially to the SVI score for each applicant. So they had to assign an applicant as likely to invite for an interview or not, and they had a score for that. And then, so after that first assignment, they were blinded to the SVI score, and then they were given that score, and they had to make a second assignment. And they found that knowing the SVI score actually only changed about 7% of the applications of the likelihood to interview score. So it really didn't change the faculty all that much. The ones that were most likely to change that score were in sort of this bottom cohort. So in the with a score of less than 11, they were less likely to be invited for an interview after knowing the SVI score. Now, there was a small subset of applications in which the videos themselves were viewed. So these were 20-minute interviews. A small subset were actually viewed. And in this small subset, actually about 23% of applicants were actually changed in terms of that likelihood to interview score. So the takeaway is, I think there are multiple factors that go into our decision to invite someone for an interview. We're still trying to figure out whether the SVI score really, how that contributes to our decision-making process. Perhaps viewing the videos themselves might make a bigger difference than actually knowing the score. But I think, with each institution getting over 900 applications, that's probably not realistic. So more to come on this as we continue to get data. The next paper is about medical school interviews. And this is a study of 5 different California schools comparing the multiple mini interview with the traditional interview, and perhaps how they might predict academic performance as measured by honors grades and shelf exam scores. So they were very, very specific. And for those of you who may not know, the multiple mini interview in a nutshell is 7 to 10 very short interviews, about 10 minutes each, very standardized scoring, and the raters themselves could be faculty, could be students, could be patients, could be nurses. So they're getting about 7 or 10 of these different perspectives on each applicant. And essentially what they found was, you could see the left column is MMI, and the right column is the traditional interview, which is 30 or 60 minute interviews with a faculty member or student. And in the first row, this is number of honors grades. So a low score is 1, a high score is 5 on the MMI. And you can see there's some correlation between a higher MMI score and a higher number of honors grades. Not as much correlation with the traditional interview. The second row is the shelf exam score, so also a little bit of sort of correlation between higher MMI score and less so with the traditional interview, and then not much correlation with the USMLE Step 2 CK score. And so, again, this is not to assess performance, so they're not looking at how well they are, in the clinical realm. This is honors grades and shelf exam score, but perhaps having multiple perspectives on an applicant may give you a better sense of who's going to be able to succeed based on this very narrow definition. Here's a page from the tear out section, or the last page of academic medicine, and this is sort of a plug for these are very short summaries focused on a topic, and this one's entitled "We're Not Too Busy Teaching with Time Constraints on Rounds or on a Busy Clinical Shift." What I like about this one is it divides sort of time into 30. If you have 30 seconds, you can maybe focus on something very specific, like a question, what is Charcot's triad, or demonstrate a specific physical exam. If you have 2 minutes, you might be able to go more deeply into a problem or a framework. And I think this might be really helpful for you as you're coaching a senior resident just learning to do some bedside teaching, or the junior faculty member who might need a little bit of an extra boost or a resource to improve their bedside teaching. This is a framework. As an educational nerd, I love frameworks. This one may seem a little bit busy, but the general idea is actually pretty simple. So as many of you know, we start with some goals and objectives when we design an educational session. So we teach it to a group of learners, we assess them before and after the educational intervention, and then we look at how well they perform maybe a month after your educational intervention or 3 months after your educational intervention. And what this paper does, it actually adds sort of this piece to it, which is, let's look at patient-oriented outcomes as a way to assess the effectiveness of our educational intervention. So this, of course, is focused on clinicians, but here's another way of looking at it, which is, let's say that instead of hemoglobin A1C, so this is a medicine clinic, let's say this is the number of head CTs we order for kids in an emergency department. What is the percentage before your learning activity? And let's say your learning activity is, I'm going to teach everyone PCARN or add PCARN rules to your EHR. What is the percentage after your learning activity, and what would it be a year out after your learning activity? So sort of looking at retention. So this is just another kind of framework to help you design your educational intervention, primarily targeting clinicians. And then finally, I love this paper. It's a quick read. It's in the journal GME, and it's talking about Gen Z. So Gen Z is the I generation, and they are about 22 years old now. So I think in the next few years they'll be entering, medical school and entering the clinical environment. So we're not talking about millennials anymore. We're talking about this new generation, and I think we all need to learn about how to more effectively collaborate with and learn from and teach this new generation of learners. With that, David's going to take the next session.
Okay, so this is our last rapid fire section where I'll go through a series of articles and then we'll transition to the deeper dive and gauge a little bit more audience discussion. So if you're looking on your left, you might see the duck. If you're looking on your right, you might see the rabbit. And this is an illusion. And these authors would like to talk to you about another illusion, the illusion of grading, and just that it lacks subjectivity and it's not the ideal form of assessment for third-year clerkships. The problem with grading is that it's focused on separating learners. Whereas for third year, it really should be more about competency-based and creating a model and environment that allows every learner a chance to succeed and to achieve the levels necessary for performance. These authors also argue that grading is limited. To say that something as complex as clinical performance can be simplified into a single letter is a bit much. Also, grading is limited is that the data upon which it's based can be flawed. So grading doesn't do a good job of embracing contextual factors, such as when students work with different attendings or see different patient cases that carry different complexity. And grading can also be prone to creating inequality. This is especially true in clerkships that over-rely on shelf exams, which are known to carry racial inequalities. So these authors want to see us on the end of the table, the future vision. They want us to work in clerkship should be in an environment where assessment is for learning rather than assessment of performance, where learners and students are active participants, their direct observation is very frequent, assessment involves multiple tools, which are narrative-based and involve self-reflection. And assessment itself involves maybe a committee of expert educators rather than single clerkships. And the advantage of this is in an environment where assessment is for learning, students are relieved of certain pressures. They're not threatened by questions. They see them as learning opportunities rather than as chances of being exposed to being a weaker student. Peers are collaborators, not competitors. And faculty are coaches, not judges. Now the authors are not ignore the fact that when it comes to residency, we do need to separate learners, and that can come in fourth year. But they're advocating for more of a competency-based assessment in third year. And these authors are from San Francisco, and they have actually just moved to a pass-fail system this year. So if you're seeing applicants from San Francisco, just know you're not going to be seeing high-pass honors from those students, and next year Esther can tell us how it's going. Okay, this is another last page. So one of my interests is in clinical reasoning. How many of you have dealt with a difficult learner who's struggling? I expect all hands to go up. I'm going to give you 2.5 things. I wish I had 3, but I have 2.5 that really were very mind-opening to me in addressing a learner that's struggling. Because often for me, when I see a learner struggling, I said, okay, there's a problem here, but I may not have the vocabulary or terminology to describe what I'm seeing, and then therefore turn into a remediation plan. This last page does a great job of informing us of important theories that inform our understanding of clinical reasoning. So illness script is the idea, it's not just what you know, it's what you have know organized into scripts that are really important for making efficient and timely diagnosis. Dual process theory is the idea that we make diagnosis at a subconscious level sometimes, and in complex levels we go analytic. But if we don't have both, we're not going to become expert clinicians. Situativity theory is the idea that not all chest pain is the same. Sometimes contexts matter, patient preference, family preferences, and if a learner isn't seeing the greater context, it may have to do with this understanding. And then heuristics and biases are important in our discussion of cognitive and diagnostic errors. This came out in 2013, and this to me is still the best classification system of diagnostic errors that I've seen. If you haven't seen this, I just kind of wanted to bring this into the dialogue. And what they did is really they created this 5 common prototypes of clinical reasoning difficulties. Again, medical teacher 2013. And for each kind of difficulty, they have a card. For sake of time, I'm not going to be able to go through all these. But they describe this. If you're seeing this type of behavior, you may fall. This is prototypically the type of problem. Here's some examples of that behavior. And here are some strategies of how you might address it. more recently, they kind of adopted this framework into a larger guide of diagnosing and managing clinical reasoning difficulties. It's an AME guide from teaching and learning. And here you can kind of see they embraced these different prototypes into a nice table. There's a problem is that can they not problem represent? Can they not move from the detail to the abstract? Are they not going in with hypotheses and their history taking is just all over the place rather than hypothesis directed? Are they doing premature closure? It's a great table, very useful tool if you're working with a struggling learner. Okay, slightly transition into kind of a theoretical, but we have a large community here of medical educators, and I think it's really important that we're all informed of some changes that may be going in undergraduate medical education. Some of you may be at schools that have already gone reform. My school itself is now taking a fresh look at our curriculum and trying to prepare ourselves or optimize it for the future. So October was a big time for this. Medical Teacher had a series of articles, and Academic Medicine, their issue, had a series of articles as well, slightly different flavor. But just to give you a feel, in the medical education, these are kind of the topics they were talking about, is that medical schools can't practice in ivory tower anymore. They have to be connected to their health system. They have to look at the health challenges their system is developing, the patient populations they're caring for, and make sure their curriculum is linked to the real world. We have to make sure our learners are ready for just-in-time learning, give them a core, but more importantly, make them ready so that when they see something they're not familiar with, they know how to access and critique information. Learners are engaged as partners. Curriculums are dynamic. They can tailor to individual students and embrace technology. And lastly, in the academic medicine, very interesting dialogue about the third science. So when I was in medical school, it was all about basic science, anatomy, physiology, and clinical science. Can you diagnose? Can you do an exam? Now we have health system science, and medical schools need to embrace this third science. So this is making sure our learners understand population health, social determinants of health, electronic medical records, and even policy. Can they be future agents of change so that we have control over our own profession? So very kind of thought-provoking articles. Okay, with that, I'm going to turn it over.
Hey everyone. So I'm a PGY2 at the University of Michigan. We're going into our more deeper dive sort of section, so I'll go through three papers and then we'll open it up to discussion. First of all, who's a resident in here? I'm sorry in advance. We're talking about burnout. You're stuck here. I'm sorry. So the first paper I want to talk about is the Internal Medicine Residency Program at the University of Washington. Did a study where they surveyed resident PGY2, PGY3, and recent grads that had recently gone through burnout and had recovered from it, self-identified. They had 25 residents. They went through this semi-structured interview, basically asking the circumstances under their burnout, what helped them recover, things that were helpful for them to overcome burnout, and the main one is down in 9, where do you derive meaning in medicine? They identified 2 different types of burnout. Circumstantial burnout, which is the thing you normally think of when you have like hard rotation, deal with difficult attendings, co-residents, difficult patients, Cerner. Basically, they found out that like as soon as you get done with that rotation, you get done with those difficult attendings, you sort of get over that type of circumstantial burnout. Other types of circumstantial burnout are things like financial struggles, difficult relationships at home, and basically they found taking more time off and having time to see your family, see your friends, get out of the hospital are easy ways to deal with this circumstantial burnout. The harder one to deal with is what they deemed existential burnout, which is basically how budding physicians view themselves in the landscape of emergency medicine specifically, or internal medicine for them. The main thing that they found is we all come into residency knowing about burnout and really try hard to avoid becoming burnt out, but then when we do become burnt out, we have to deal with the stigma of being burnt out, and that's really hard for people. And the main way they found to deal with that is recognizing that you're burnt out so you can take that next step. Interestingly enough, they also found that attending validation, like getting into an end of a hard shift and the attending being like, look, this was hard, but you did a really great job. I'm glad I worked with you on this shift. Just feeling validated really helped this form of existential burnout. They also found forming connections with your co-residents and your patients was really helpful. So they do something each month at the University of Washington called Death Rounds, which isn't M&M, but it's basically the residents get together once a month and discuss issues that they had during the month, difficult patients, difficult cases, and are able to just sort of vent about the issues that they had. And then also sort of developing like your own sort of niche in like medicine, finding why there's difficulties with people coming into medicine, seeing like the glamorized form that is on TV and stuff like that, and then getting into residency and realizing it's not what you expected, and people really struggle with that. So they found that finding different ways that you find that you belong in medicine, either ultrasound, critical care, stuff like that, finding stuff outside of your just typical work really help people improve from this existential burnout. Moving on to this next paper, this was a group at Northwestern that sort of compared burnout with Press-Ganey scores. And I realize that Press-Ganey scores aren't great, but the reality is 40% of hospitals use them to gauge patient satisfaction. So they did a burnout score. They didn't tell the residents they were measuring burnout, but they basically, it's called the MLASK Burnout Inventory, and they had them fill out this inventory, and sorry, I wrote it down in my hand because I can't remember the numbers. Depersonalization scores down in the bottom score greater than 10, and emotional exhaustion greater than 27 was deemed as being burnt out. And then they added 4 questions to their Press-Ganey surveys that they sent to 30% of discharged emergency medicine patients, basically asking about resident physician, how courteous they were, how much they cared about their care, how well they kept them informed. So first of all, they found that 78% of the residents were burnt out, which is quite high. And then they also found significant differences in each domain that they measured as being significantly different, that more burnout residents had got lower Press-Ganey scores across all domains. So it is important. And this last study I want to briefly go over so I can open up to discussion is basically a group in Canada where they don't have duty hours, looked at the impact of sleep on being burnt out. They had a surgical cohort, which was gen surg, orthopedics. They had a medical cohort, which was internal medicine and neurology, and an RCD, which was radiology and anesthesia. And basically, I just want you to look at the top line of this chart. You can see the surgeons work significantly more than the other two, which is obvious. But they also found that surgeons had statistically significant differences in the amount of sleep that they got compared to the medicine and the RCD cohort, but it didn't actually impact burnout. Which leads us to think that other impacts other than just sleep are causing this burnout. And they actually found that there was increased burnout scores dependent on the length of time you were on call, specifically. So I want to open up mainly, like, this is a very hot topic, especially in emergency medicine right now. At your shops, is there anything that you found that has helped with your residents' burnout, or something that didn't work at all and actually made things worse?
At our shop, we changed, we had a monthly journal club that we'd been doing forever at a faculty's house, and we actually changed to including our critical appraisal of the literature into our conference time, and actually taking a lot of the discussions around wellness out of conference time and putting it into that time at a faculty's house. And we have around where faculty will tell stories, and it sort of opens up, like you were talking about, those death rounds, like other people to actually tell some stories and express some of the feelings that they have. And we have sort of all different presentations, small group style, and that's worked really well for our residents.
Can I ask how you picked how you did the discussion, how the topics, how you focused it? Because that could be huge.
So the first thing we did was we went through the curriculum and sort of picked out all the things that we thought were more appropriate to be in the setting at the faculty's house and in a small group style, and we're just going to be more effective that way. So that was our first step. And then we actually we sort of started the first year saying, here's what we're going to do, and pairing them together. And we noticed that some of them, we got feedback, that some of them we had put too many sort of, as our residents call her, the downer discussions all together at one time. And that they didn't like that. And so now we actually make it a point to have one that's sort of maybe a little bit upsetting, and one that's sort of not. Like some of the financial stuff goes in but we put that, we'll match like financial with something else. It's going to be a little more upsetting.
You know, this is such a huge topic, it's almost hard to say anything that we haven't all heard before, but my own gut feeling about this, certainly having these conversations is great because it does give people a chance to talk about it. But I think if we're going to really make a difference on the whole burnout area, we need to probably take small bites, bit by bit, to finally get this. And I would suggest that we really look at the most vulnerable groups, women who are pregnant, having babies, and trying to do that and come back to work. I think others who maybe have illness or injuries, things like that, and figure out what can we do for those folks who really, I think, are most vulnerable to being burned out and ultimately even quitting sometimes. And then get to the next group, probably the surgeons, the people who are working the longest. Ultimately, I really do think the amount of hours that we have people working is really the number one thing. Resiliency training, things like that, people talk about it being helpful, but you know, my sense is that a lot of our residents just don't, they don't want to go to another program where they have to actually sit through and learn how to not have a crash on the way home after working for 30 hours or something like that. So I guess, I think we need to just take this thing much more seriously and realize how much pain we're causing in terms of particularly our women who are trying to have families, and to some extent the men, and focus on what we can do for them. And if we do that, and then we go after the next group, bit by bit, I think we'll eat this whole elephant. But the problem is it's just so big that every time we try to come up with a solution that'll work for everybody, there are too many reasons why we can't do it. We can't cover all the various clinical things, and so we then end up not doing anything or not doing enough. So anyway, that would be my suggestion.
Thank you.
Hi, I'm Doug Finnefrock, the Residency Director at Hackensack University Medical Center in New Jersey. I think the biggest thing we did is, in our region, it's very common for resident schedules to be 12 hours, and I think the biggest thing we did was completely blow up that schedule. Make it all 8 and 9 hour shifts with overlapping shifts. Every single night shift, overnight shift that residents do are only 8 hours. They begin at 11 o'clock and end at 7. So it's respect for their time off. It's building in the wellness into their day, and and really listening to the residents and being able to make that change.
Thank you. I think we have time for one more.
I mean, we've done two different things at our shop. We've incorporated quarterly wellness events about 2.5 years ago now. I'm the program director at Penn State. And we approach wellness-themed topics, sleep hygiene, organizing your whole life. Like, my whole family color-coded Google Calendar that my husband's call schedule and my schedule and my kids' schedules are on. And then we always have a team-based activity afterwards. And those are really fun. But I think it goes down to the simple things. We just had our R1 and our PGY 1 and 2 retreat a few weeks ago. Letting them have a few wins. Like, hey, we hate these evaluations. We hate having to evaluate every single conference. No one does them. The one sitting next to me here gave a suggestion, and we're like, we can implement that in 2 days' time, and it's an easy win. And letting them get some of the complaints out of their system, yeah, everyone's going to hate their trauma rotation. I'm not going to fix that. But I can change an evaluation in a week, and letting them have some easy wins and get it out of their system kind of just does a whole lot for resident and group morale.
All right. Thanks for participating, everyone.
Cool. Yep. All right. So for this final segment, we are going to pivot to a surgical paper. So you may ask, why at an education lit review are we going to be talking about complications in bariatric surgery, which is an excellent question, and I will tell you. I think a lot of us might agree that the holy grail in education research is if we can link educational interventions to patient outcomes. And this group in surgery is doing this, and I'm going to bring up how we could potentially apply this to emergency medicine. So this group that started out of Michigan started this study where they have surgeons videotape their operation and then send out those videos to other surgeons for peer review. Those surgeons then will provide peer feedback and give it back to the people and rank them into different quartiles based on their perceived sort of peer rank of level of surgical skill. So they're put into different quartiles, quartile 1 being the lowest, quartile 2 and 3 in the middle, obviously, and quartile 4 the highest. What's interesting is a couple things. First of all, if you look at the characteristics between surgical skill and those that separate the first quartile from the fourth quartile, you see that the number of procedures matters, and this is obvious, right? Those who are doing more surgeries should have higher clinical skill, and that did bear out in the studies as well. So these were anonymously reviewed and videos that they didn't see ahead of time, or they were not identified ahead of time. And those who were performing more surgeries were ranked into the higher quartiles. What becomes very interesting is when you look at patient outcomes, those who had a higher surgical skill rating had fewer patient complications in the long run. And so, again, this is something that you might expect. If somebody is performing at a higher level, you may expect to have fewer complications from patients if they're doing better surgery. It makes sense that if you're doing more, that you're going to have higher skill. What about educational interventions? So this same group then provided feedback to the initial surgeons and found that you could take a quartile 1 surgeon and move them into quartile 2 and 3 by peer feedback. This is hugely impactful. This is an educational intervention that is moving skill levels quartiles, independent of number of cases. That is highly suggestive of big educational intervention that can impact skill in the long run and may then correlate with fewer complications for patients. So where does this come up, or where could we apply this to emergency medicine? This is a graph showing the same thing. And so the top quartiles had fewer complications at various time points. There was a group in China that published a paper on resuscitation where they videotaped their ER bays and the resuscitations that took place. And they said, we're going to videotape all of the resuscitations, and these are medical resuscitations of coding patients, and ask how are they performing on CPR, simple CPR. And they found that the mean time to starting chest compressions was reduced when you showed video feedback and had people review that a week after they did a resuscitation. So there is a precedent for this. There's only one paper on this. This is actually from 2010. So I wanted to bring up the question, how many of you guys at your institutions are currently videotaping medical or trauma resuscitations? A few people. How many people have the capability of that? There are video cameras in place to do that. What do you guys foresee as barriers to doing this? So video cameras is one. What are some other thoughts about, is this doable at your institution? What are some barriers that you imagine in place to being able to videotape resuscitations and potentially intervene on that?
We have 3 levels of trauma. Level 1 and level 2 are primarily trauma, and we do airway. And then we have level 3s, which are run by our department. Kind of lower acuity, but hemodynamically stable, but maybe need expedited imaging, stuff like that. And our staff, we don't put our strongest nurses in the level 3 traumas. Our staff act differently. We don't have the same nursing ratios in those traumas. We don't treat them like level 1s and 2s, and therefore we don't video them. And it's really up to the documenting nurse to turn on the recorder and getting the buy-in from all of the staff. So we started re-videoing them, and I'm all gowned up, and they're like, it's a level 1, and they're like, oh, we're doing this again? So I don't think it's come from our faculty. It's really come from our support staff, the resistance to it.
Okay. Okay, good. There was another comment back there. Let me respond to that. So we are videotaping resuscitations at our institution currently, and we had a similar barrier, which is when do you press the go button and who should press that? And that's a question that has come up. And so what we're doing now is we have a nursing staff team that is pressing the go button essentially at the beginning of every resuscitation and then asking the question later, are we going to use this one for review? And so we've made it sort of standardized to say we are going to videotape every single one and then down the road we'll decide if we're going to use that or not, which presents its own set of challenges, but we have a team dedicated to do that. That is a sort of thing that we encountered as well. Yeah, there's a comment back there.
So we are currently videoing some select medical resuscitations. And I won't get into the details of that, but the biggest pushback that we had in implementing this was actually from nursing staff in the other way. They were very nervous that we were going to use this against them, that they were going to be evaluated, that they were potentially going to get demoted or even fired because of something that happened while they were being recorded.
That's an excellent point. So the comment was about how nursing staff were concerned that they maybe on video review seemed to do something problematic and then potentially suffer consequences from their actions. That does bring up the sort of the consent feature of this. So our legal team said for a while, this is potentially problematic. And so we're not sure if we can allow you to do this. And then going through the whole IRB review is obviously a big deal. What the surgery groups do and what you can do in the resuscitation groups and what this group did is the IRB consent, the subjects are the residents in this case. And so the support staff like nurses, I guess, would probably have to be consented as part of the same process if they were being interviewed. And then the patient information is completely de-identified and left out of it. And so the patient is not consented. But you raise a good point, which is that when we're thinking about who our subjects are as part of this research and who should be consenting, we need to have a system in place where we're talking to all those who would be videoed, so residents, nurses, and then think about ahead of time and be proactive about, this is for educational purposes and independent of other consequences. Awesome point. Yeah.
So you brought up legal, and I think at my institution, which is, let's go conservative and risk averse as descriptors. I think that the pushback we would get, and we've sort of talked about this in vague terms, but never really taken it very far, would be a risk of exposure to medical legal risk, malpractice risk. Because even if you de-identify the patient in some way, these videos are likely time and date stamped, and so the question is, how do you bring this to your risk management, your legal, the hospital administration, in a way to sell it to them on the educational value and minimize their concern about potential hospital risk? And I'll close by saying we're not a traditional academic medical center. We're a community hospital with a handful of residency programs that's a part of a larger community health system. So It's a little bit of a different model.
Yeah, it's a good point. So this is something that we've encountered as well, and our sort of early stages on. But I think one way to frame this is that this is a huge part of quality improvement. We want to know if people at our institution are doing things incorrectly, right? And so instead of being a punitive thing, we want to say, hey, are people making mistakes? Are we not doing CPR correctly, right? Are we not running our ABCDs in our trauma resuscitations as part of sort of overall quality control for the institution? And if you frame it as a quality improvement and educational project, I think that you could get a little more buy-in from the institutional leaders, and again, sort of being upfront about this is not punitive, this is quality improvement and potentially educational. But yeah, absolutely, these are barriers.
I don't think that the concern would be punitive. I think the concern would be, the billboard lawyers taking their hands on these videos and then, tearing us apart in about practices.
Right. Yeah, that's a good point. So and then some of these groups will delete the videos after 30 days, and so they're coded and reviewed and then removed. I don't know if that gets around it, but then it's not available.
I just want to add that's what our institution does. So we actually don't need to press this on and off button. Any sort of action actually triggers the video to just start recording, and then there's some limited capacity, and then you can download your video, but then we're required by our legal sort of language for using these videos to delete them once the appropriate information has been viewed in an educational conference or things like that.
And I think that because there are other groups doing this and studying this, we could reach out to each other about how this is handled as well.
Yeah, a question. Why wouldn't videos such as these be considered quality improvement and free from discovery, immune from discovery?
I don't have the legal
That's really
answer.
what we're using them for.
They are.
So the comment was, if it is quality improvement, most states make it not discoverable.
So I'm at a large academic institution. We do not have video recording of resuscitations, but I have, with approval of my department and the privacy people, started auto-recording GlideScope videos from airways, and they are incredibly helpful in doing this. So that's honestly something that's relatively easy to do. Any VL system probably has some sort of option where you can auto-record videos. The thing I would say is that while the videos of the inside of someone's airway are obviously de-identified and not usually an issue, I will say when you do the auto-record, you may when the blade is down, you may end up picking up things inside the resuscitation area and things that could be considered identifying information, but this isn't something I've been able to study formally. It's something that we just kind of started piloting. I'll tell you, the data is incredibly valuable. You show a resident what they did and didn't do on an intubation at a slower pace, afterwards, and it's great. And I think the video manufacturers are going towards this. Like the new GlideScope systems have internal memory before it was a thumb drive that you recorded the videos onto. And I told them, I was like, if you guys want to really take this to the next level, make it cloud-based, make it wireless, put these videos up into a HIPAA-protected cloud, and then review later. I think those things are coming, at least as far as airway is concerned.
I'm glad you made that comment. So we'll have to wrap you up here, but the comment you made particularly about these videos are effective, right? You show the video and provide feedback that way, and it works. And I think part of the reason we wanted to bring this up is to say this is a potentially hugely impactful area. We're talking about feedback and an educational intervention that may be able to be linked to patient outcomes down the road if we are able to sort of overcome some of these barriers. And we should be doing this. The surgery groups are doing it, and it's published in JAMA New England Journal. They're obviously hugely impactful studies. It is demonstrating a big impact on education and educational interventions, and there's no reason we shouldn't be thinking about doing this with individual procedures like you mentioned with the GlideScope and airways, and also our resuscitations and work on critically ill patients. So thanks for that discussion.
So we'll close. If I could just prompt in closing just to remind you to please provide feedback for this session. I'll tell you, in doing these journal clubs, we're always trying to find this balance of going through lots of articles, doing deep dives, and creating space for audience discussion. So if you have any thoughts on how this balance felt for you, we would very value that, deliberate practice, so appreciate that. But thank you so much for coming and for engaging in discussion. It was very enjoyable.